Charles Clinton. Today I will talking about NSTEMIs everywhere. That's the title for my lecture. And without further ado, let's go back in time, almost to the start of time, but not so close. So let's better go back some centuries ago. So this is the first description of chest pain we know of. So this was from a physician called Benivieni, a Florentine physician. And in the 1500s, he said about a man with chest pain, he was seized by so sharp a pain in the left arm that the torment made him pale as he were dead. And he used to say that he passed the pangs of death, and that he should die in one of those fits. As soon as it was over, he was the cheerfulest man alive. Interesting. That was the first description of chest pain. Now, let's go on to see that's a syndrome, right? Chest pain is a syndrome. So let's talk about what came afterwards. Let's try to get closer to our topic, acute coronary syndrome. So here we have the father of clinical observation, Sir William Heberden the Elder. So this is his description in the year 1772. He said, "There is a disorder of the breast, marked with strong and peculiar symptoms, considerable for the kind of danger belonging to it, and not extremely rare, of which I do not recollect any mention among medical authors, because you were the first one. The feat of it and sense of strangling and anxiety with which it is attended may make it not improperly be called angina pectoris." So this is the first mention in history of the word angina or angina. Not sure how to pronounce it. I've heard it both ways. So in summary, the word angina has a great connotation to it, meaning that strangling pain usually associated with an acute coronary syndrome. Okay, so why is the number one right here? It is here because that's the first thing we have to take into account whenever we are thinking about criteria that should be met for us to diagnose acute coronary syndrome. We have three different criteria. This is the first one, and in this order. Number one, history and physical examination. From there you get the symptoms. Then comes number two. What is number two? What Amalma-2 would tell us about. So if you've ever seen them, you know what I'm talking about. If not, I highly recommend you seeing his videos on electrocardiography. So for sure, criteria number two is get an EKG. You cannot think about acute coronary syndrome if you do not have an EKG. That's your second step. And your third step, last but not least, yeah, for sure, but third and last in that order are your cardiac enzymes. Okay, so cardiac enzymes have changed a lot during the years, but just for us to remember, these are the old ones. Myoglobin is old. AST and LDH are the way old ones. These are the ones that your cardiologist that has been practicing for 30 years will tell you, oh, in our time we measured this and the AST and we saw the LDH and we combined all these and thought it was maybe cardiac, right? Why did they have to do all these studies? Because they didn't have anything that was sensitive and specific for the heart. So they had to indirectly come up with this adding up of possibilities. But later came something that was somewhat sensitive and specific, which is the creatine kinase. So in this one, you also had a relationship, which was the total creatine kinase to the CK-MB isoform. And that told you this is probably the heart. It was pretty good, pretty respectable, but nowadays it has been widely replaced by the troponins. So the troponins nowadays, and the last guidelines from the major associations, which are the European and the American Heart, basically it says this is the one you need. Which of the three? Well, remember that the troponins have three subunits. There's I, C, and T. It's the same thing that's attached, and basically the C is the one that's attached. I think it's to the calmodulin, and let's not go into that because it would make the lecture too long. Basically, the C is in a specific. You can also see it in other striated muscles, so you won't use that one in clinical practice. For the heart, you will use troponin I or troponin T. In our hospital, we use troponin I, which theoretically is a little bit more specific just to the heart, but it can also elevate a little bit in other contexts. Okay, so this is basically what we already talked about, the 3 criteria. This is just emphasized by the 2021 chest pain guideline from the American Heart Association. What I want you to see here is that first comes the symptoms, second comes the EKG, and maybe yes, maybe not, the troponins. So symptoms and EKG make you think of a non-cardiac cause, you don't need troponins. If it makes you think of cardiac cause but not acute ischemia, such as a patient with heart failure that went to Mexico, ate too many tacos with salt, and now has increasing bipedal edema, yeah, the patient needs a little bit more Lasix, and remembering they shouldn't do these dietary transgressions, right? They don't need a troponin probably. But if you think the patient has acute coronary syndrome, that's when you order a troponin. Of course, there are a couple other exceptions where you can order a troponin that you're not thinking of acute coronary syndrome. I'm just going to mention a couple. Stratifying pulmonary embolism and or pericarditis that you think they are having a little bit of myocardial involvement. So those are the main ones. But other than that, if you're not a cardiologist, I would not recommend you ordering a troponin if you're not in the context of acute coronary syndrome, because it might be more troublesome than beneficial, and we'll probably see that soon. Okay, so those are the 3 items or criteria you need. You already know that you need 2 out of 3 to make the diagnosis. And I think that until now, we have been able to explain it pretty simply, and it means that I maybe understand this. So Einstein is smiling. But wait till Einstein, well, he already knows about our next patient, so he is already serious. Why is he serious? Because this is our next patient, a 28-year-old obese male with epigastric pain diagnosed with DKA. Oh wait, and the troponin was high. So this patient came in the ED with the epigastric pain, and yeah, and he got a troponin. Why is that? I have no idea. Is that in the file? No. Does the patient say anything that would make you think the patient had acute coronary syndrome? No. So why is the troponin there? We don't know, but it's there. So what can you find in the problem list? You can find a wide array of diagnoses. You can see them there. There are some I don't like for sure. There are some I despise from this list. There are some I'm okay with. Of course, now that the troponin is there and it is high, you have to address it. You can't just ignore it. But I will just remind you that troponinemia isn't a diagnosis. It's just telling you that troponin is high. It's not even a sign, right? It's just a laboratory derangement. So I'm not sure if that should go in the problem list. You should try putting that together into something, because if not, we're gonna have a problem list that says troponinemia, lipemia, transaminasemia, and all those things, and we don't know what's going on in the end. Troponin leak is another one I don't like, because I don't read it in any articles. I don't see it in medical literature. So it makes us look like we're dealing with plumbing things, right? Like if it's a faucet that's leaking, and it doesn't talk that well about the pathophysiology. I like more this term, myocardial injury, because yeah, where is the troponin? It's inside the myocardium. Is it injured? If you have increased troponin, yes, it's injured. It's not an NSTEMI. It is, well, it's a term that also is found in medical literature. So that's a better option. But of course, you have to see this in the context of what's going on. Okay, so my PICOS trial, basically, this is my work in PICOS, my work in PICOS question. So this is unaltered from how I started. I saw those patients with low pretest probability of coronary chest pain, and I wanted to know what happens after troponin is measured, what are the outcomes of these patients, do they improve, is it indifferent, or do they worsen? And type of study, whatever I would find, because that's the idea. It's difficult for you to find a randomized control trial about this because it's impossible and nowadays to basically go into an ED department or a ward and just say, okay, this patient has, let's divide this in two groups. This patient with chest pain, order a troponin. This patient with chest pain, don't order it. Or it's very difficult. It's difficult to make such a comparison because I'm sure that you would get ethics involved and this isn't that straightforward. So probably the best studies in this area for this question would be observational, because we already have guidelines that are telling us like what to do. And yeah, so D-dimer is in red. Now what? So we know we're not talking about D-dimer. I just put that there so you remember the difficulties we've had with D-dimer in the past, and we might be having that with troponin as sensitivity of it goes up. So D-dimer in the past, it has been very controversial, and probably it never had to be controversial. It got controversial because it was being used incorrectly. So everyone was getting the D-dimer assay and everyone, it was turning out positive, and suddenly you were doing so many CT angios when you didn't need them, until you received these statements of the major medical entities saying this isn't the way you use D-dimer. D-dimer is used for its negative predictive value. It's not a rule-in test, right? So for troponin, I'm not saying it's going to be the same, but I'm saying that there's also a long way to go. And yeah, the troponin is red. Now what? So these are the patients we've encountered so many times in practice that you don't know why the troponin was ordered. It just was ordered. Now what to do about it? So I'll just go through a couple of them. Should you consult cardiology? Should you deprioritize the problem until it disappears? Should you just mark it as resolved? Should you open up Pandora box by bringing it up on rounds and saying, hey, the troponin has been elevated and suddenly I didn't see any mention of it for the past 3 days. We haven't done anything. Are we doing something? So maybe someone will say, oh, let's get a stress test. Oh, let's put the patient on a heparin drip. So yeah, that's the Pandora box, and it will happen. And yeah, watch out. Or reread up to date to see if there's any new information about this, right? Okay, so basically the evidence we've already talked about. We've already talked about the guidelines. So that's the maximum level of evidence we're going to talk about in this lecture. Basically, the guidelines, we already saw the 2021 algorithm saying if you don't think the patient has an ACS, don't order troponin. But you got the troponin anyway. So now what? So that's the next evidence we'll see, which are mainly articles and expert opinions. So this is one problem of the troponin, is using it incorrectly on the population it wasn't meant for. The second problem I can see about it is that a more potent tool leads to more potent confusion. So add to that you're using it incorrectly, it probably duplicates the possible confusion. So this article basically tells us how to interpret elevated cardiac troponin levels, and Yeah, it mentions the advantage. We all know that less potentially missed ACS diagnosis, yeah, but there's a decrease in sensitivity that I'll explain in the next slide. What I want you to see here is what happened in Brigham and Women's Hospital after they replaced their regular troponin to the high sensitive troponin in 2007. They got double the positive results of troponin in their ED department. Not 10 to 15%. They got double the amount of positive troponins. Does this mean that suddenly our epidemiology changed? No, the lab changed. So with such a sensitive lab, what are you gonna do? Hopefully use it a little more correctly. So here we'll see the diagram of how it has evolved in time. This is 1995. So in 1995, you needed the patient to have approximately 8 hours after the inciting event, which would be chest pain, for you to be able to say, okay, are we capable of detecting troponin if it's elevated or not? Okay, so it wasn't very sensitive. In 2003, we get the CTNI, which is basically high sensitive. As you can see, that's why the cutoff value changes. We go from 1.5 to 0.10. We're talking about an order of magnitude of 100, let's see, more than 10 times approximately. More than 10 times sensitivity, which is a lot, right? So here we can detect the patient's troponin elevated at 4 hours. And if we see the last high sensitivity troponin, which is the ultra, we can detect the patient in approximately 3 hours or even less. So in summary, you have to know what assay your hospital is using. Because, for example, my hospital, it's the year 2022, but it doesn't mean that we're using the 2007 one. We're using a high sensitivity troponin, or that isn't even called high sensitivity, but it's analogous to the 2003 due to the cutoff value we have for our hospital, which is very similar to this one. So you have to know where you're working just so you understand this a little bit better. Okay, so basically, the most important thing I want you to pay attention here is what's happening in this curve. We're going to the left or going to the right? Yes, we're going to the left. So if that's what's happening, let's see what happens to sensitivity and specificity. So here we have the true negatives and here we have the true positives. So now let's mark a line on, this is illustrational purposes only, but this will help you understand it. So here we have the 1995 test. Here we have the 2005 test. Okay, so we have a left shift. With the left shift, what you have is an increase in sensitivity. That's what everyone talks about. But not many people are talking about the sensitivity, the specificity. Okay, so if you have an increase in sensitivity, you also have a decrease in specificity. So, increase in sensitivity is the same as saying you're detecting almost all of them, but the ones that are positive, you don't necessarily know if they have the disease. So you have a very high rule out capacity, but you don't have a very high rule in capacity because sensitivity rules out. High sensitivity rules out, but you're losing specificity, and specificity rules in. So what happens? In the ED department, this is good for the ED department because they're able to say, okay, this patient is going home. This patient has a high troponin going to the wards, being admitted. Being admitted, why? We don't know, but the patient has higher mortality because the troponin is high. go to the wards. Okay, but in the wards, you don't know what to do because you go through the file and you see there was a low pretest probability, but now you have to deal with a patient with a high troponin, so you don't know what to do. So the rule-in capacity for the troponin and its increasing sensitivity is actually worsening the thing for you, making you have to see what's going on. And even worse now that we have higher sensitivity troponins. So that's, again, a call towards using the assay correctly, because if we use it incorrectly, the confusion might be even worse with this new era of high sensitive troponins. And this was 1995, 2005, and here we have 2007. Okay, so basically what you see on the right side in yellow from this line would be false positives, meaning that the patient does not have the disease, is a true negative, but is positive on the results for the troponin. So this is a patient we don't want to have because it complicates everything, and this patient may end up with a heparin drip and may end up with a severe GI bleed, and in the end the patient didn't have to go through all of that, right? Okay, so here we have the intern trying to tell the attendant why he asked for the troponin, and the attendant actually saw this lecture and mentions it correctly. So other results for the increased sensitivity of the troponins are basically that the term unstable angina is being erased from textbooks. There we have it. Why is this? Because unstable angina by definition was an acute coronary syndrome with negative cardiac enzymes. Now that the cardiac enzymes are so sensitive, as you saw with the Brigham and Women's, that double the results were, double the amount of positive results. Probably the patient that was in the past an unstable angina now is being seen as an NSTEMI because the higher sensitivity troponin is detecting minor increases. And also there's another thing, that if you're so sensitive, you also have to deal with the backlash. So if you're detecting so many people with a positive troponin, that many of those people maybe weren't chosen correctly and had a low pretest probability, they might end up in one of these categories known as MINOCA. MINOCA means myocardial infarction with non-obstructive coronary arteries. This is a term that didn't exist in the past. This is a new term that has been in the latest European Society of Cardiology guidelines. This was for the 2021 ESC guidelines. So basically, a patient with a high troponin that wasn't well stratified to start with could have ended up going through all these different barrage of exams, ended up negative, could have ended in the cath lab, and could have had non-obstructive coronary arteries and ended up with the diagnosis of MINOCA. But an even worse scenario is the patient with a elevated troponin that had an initial low pretest probability, but the elevated troponin prompted to a stress test, which the stress test isn't 100% sensitive nor specific, and that might have led to the cardiac catheterization, and that isn't 100% sensitive or specific. Maybe the patient had chronic plaque and received a stent. So now the patient is on dual antiplatelets, and the patient didn't even need the stent to start with. So those are different things that might happen. So let's take into account all the different reasons troponin can be elevated. So basically, what does an elevated troponin tell you if it's not well well, prescribed. It basically tells you that cardiology is a field of medicine because a elevated troponin in 95% of occasions is telling you, or most of the time is telling you, that the heart is being stressed to a point where there is myocardial injury. What is the cause of the myocardial injury? That is up to the assessment you have done. But you can see that hypertrophic cardiomyopathy can produce it, tachyarrhythmia, bradyarrhythmia, Takotsubo, cardioversion, cardiac surgery, endocardial biopsy. So in the past, the regular sensitivity troponin would never usually increase the troponin with an endomyocardial biopsy, but now it's so sensitive that it is detecting that aortic dissection, aortic stenosis, etc. So it is very sensitive, not that specific. Yes, it is specific for the heart, usually, yeah. It is pretty specific to the heart. Not 100%, but pretty specific. But what gives you the specificity for acute coronary syndrome is your clinical decision pathway guidance with a previously well done pre-test probability assessment. Okay, so these are other causes for non-cardiac elevations of the troponins. Just so you know, it doesn't always mean the cardiologist has to be involved. If you have a patient in septic shock, yeah, the patient might not have to receive a cardiology consult. Renal failure with a troponin that is just like this, elevated, and doesn't go down, doesn't have a bimodal distribution, that's also a cause, etc. Right? Okay, so my PICOs, in the end, I found one observational study that is the one I'm going to mention right now. So it's basically the same questions I asked to myself initially. Now I'm just adding whatever I found, which is this study we'll see right here. So this is very interesting because it's observational, and I think it's a good design in order for us to see what's going on without intervening, because that's what we actually want to see, what's going on at this point in time. So this was done in a hospital where between 2011 and 2013, all the ED visits that received a troponin or that were assessed with their troponin levels, they were categorized and see what happened with them. So 1,700 troponin tests were ordered in the ED between these 2 years. Of these 1,700, 750 were abnormal. And what I like is that they excluded 338, which were those that were well ordered, that were ordered for what you have to order it in acute coronary syndrome. Or those that weren't able to be followed because they left. So the other 412 patients had positive troponins with low pretest probability. So that's interesting because, first of all, it tells you that of 1,700 patients which were ordered troponins, more than half had increased troponins. And of those with increased troponins, most of them had low pretest probability. So now what happens with those with low pretest probability? What are these stats? And right off the bat, if you read the title of this article, you can see that it's not very promising, right? It's telling you the hazards with ordering troponin in patients with low pretest probability of acute coronary syndrome. Okay, so this is the study I was looking for. It's probably not the best study. We always want to see randomized controlled trials, but in this context, this is ideal. So, what are the stats? Of those patients that had that first troponin, they ended up being trended 3 times more. So they didn't need the initial one, but it was positive, so they got 3 more. Cardiology consult, and 65% of these patients, which they probably didn't need in the first place. aspirin was started in 15.7% of these patients, increasing the risk for bleeds, and no clear reason, right? Because aspirin isn't indicated in low pretest probability and no ACS. What I find interesting, and I think might be something that makes me hesitant of some of these results maybe, is that 0% or 0 of these patients underwent stress testing or invasive cardiac intervention. So we're talking about 412 patients with positive troponins with low pretest probability, and I don't understand what happened, because if you think about it, they ordered troponins in patients that didn't need them, but they were able to filter out 100% of these patients and understand that they probably didn't need additional studies. That usually doesn't happen in real life. In real life, even the best center won't be able to filter out all of them, because there will be one of these patients that has some symptoms and ongoing chest pain, and let's get these stress tests, and usually they wouldn't be able to be so efficient, right? But that's the data we have from there. Also, of these patients, 18.9% were admitted to the CCU and subsequently transferred to the MICU because the first diagnosis was not cardiac, which makes sense. So they required a whole lot of personnel and money and everything to be treated, but in the end, they didn't need to be there. And they also required telemetry for more than 24 hours, most of them. So these are my appraisals. In summary, I would say take-home points is for you to order troponins if you think it will change your management. Number 2, have a good reason behind ordering your troponins. If you don't think you need to order an EKG with the troponin, you probably don't need the troponin in the first place. Number 3, get cardiology on board when faced with any difficult scenario. Number 4, be ready to go all the way if it turns back positive, meaning that if you have a positive troponin and you just are ignoring it, if that patient eventually starts having chest pain some days from now, or you send him home, the patient dies, you have an autopsy, or someone says, oh no, the patient had a chest pain and no one did anything about it, eventually you might go to court, they might see a positive troponin, you didn't work up the troponin, and guidelines say if you got the troponin it's because you thought it was ACS, so why didn't you do what you had to do? So you're looking for trouble. Number 5, understand your troponin assay and how to use it. This might be a future lecture. And thank you very much for your time and patience during times of high sensitivity. See you in the next one. Peace out. Gonna sleep tight and tomorrow present this. Let me know your thoughts about it. See you in the next one. Thank you very much.